See, cardiogenic shock, the management of cardiogenic shock is an art. And in my experience, I can tell you for the past 20 years, it carries a high mortality, and the outcome of cardiogenic shock treatment is directly proportional to the interest of physician or cardiologist who is treating the patient, as well as the family support, both emotionally as well as financially. If three things work together, I think we can bring out, or we can take a cardiogenic patient more properly. So whenever the first principle of managing a cardiogenic shock is, you know your patient, what kind of cardiogenic shock you are, or what kind of shock it is. Sometimes we feel, okay, patient is having LV dysfunction, it is a cardiogenic shock. It may not be. Patient may be harboring some subclinical infection, and we may be ideally treating the septic shock. So you should know what kind of patient you are dealing with, whether it's a hypovolemic shock, whether it's a septic shock, or it's a cardiogenic shock. Even in the cardiogenic shock also, there are different parameters. All cardiogenic shock cannot be treated in the one way. There are different causes, like aortic stenosis shock has to be managed differently, patient tamponade has to be managed differently, or severe LV dysfunction has to be managed differently. Definition wise, yes, persistent hypotension less than 90 millimeters of mercury, which is continued for more than 30 minutes, associated with reduce in the cardiac index and increase in the PCWP is the definition for cardiogenic shock. Most common cause of cardiogenic shock is myocardial infarction. There is a long list of cardiac causes, but yes, the most common cause is a myocardial infarction. And once we deal with the myocardial infarction, you should think positively whether if your patient is not improving, is patient belong to any of this risk category, and then you can manage accordingly. Recurrent ischemia was supposed to be one of the most common causes of cardiogenic shock, but in the present PCI era, most of the patients, they undergo primary PCI, incidence of cardiogenic shock has come down, and this because of reocclusion of the vessel, which can lead to severe LV dysfunction. And one of the autopsy study, it has been suggested that those patients who develop cardiogenic shock, almost 2/3 of the patient has severe coronary artery disease, or at least on all the three vessels. And this is a very pathognomic, like we know everything, that because of systolic and diastolic dysfunction, patient develop hypotension, reduce ischemia, and ultimately patient lead to severe ischemia followed by severe LV dysfunction, and patient succumb to death. And these are the common risk factors. Most common risk factors are old age, multivessel disease, anterior wall MI, ST elevation MI, patient with diabetic, hypertension, prior MI. These are the more risk factor for developing cardiogenic shock. So if you are dealing with this kind of risk factor patient, please suspect that this patient can anytime develop the cardiogenic shock. And as I said, the first principle, you know what kind of patient you are dealing. So is it a really cardiogenic shock? And yes, what is the severity? And then again, you have to rethink whether you are dealing with something LV dysfunction or the RV dysfunction, because again, management will be differ. And what support system you have to evaluate. So how to approach a patient with cardiogenic shock? Take a detailed history from the relative, from the patient, because each historical point will give you clue to management of the patient. Examine the patient from head to toe. Check all the peripheral pulse, and also assess the pulse volume, character, because so many times you will give a good clue from all these things, investigation. And assess JVP, its waveform, assess the heart rate, whether patient is having tachycardia, bradycardia, respiratory pattern, blood pressure. Pulse pressure is a very important thing. If there is a narrow pulse pressure, definitely patient is having high left ventricular and diastolic pressure. Look for LVS3, and look, every day you assess the patient, every day you auscultate the patient, you will definitely see some new development or heart systolic murmur, and auscultate all the areas of the chest, whether patient is bedridden or whatever, but try to auscultate all the areas of the chest. All these investigations are must. I would say that any patient cardiogenic shock, you have to have blood investigation to rule out any metabolic cause. ECG has to be done on the everyday basis. Chest X-ray has to be done. And not only doing the echocardiography, but echocardiography finding has to be correlated with the current situation. And always assess IVC if you are dealing a patient with the cardiogenic shock. And again, not only investigation, even CVP, PA pressure evaluation is as important as other blood investigation. So all patients for cardiogenic shock, if you want to treat by heart, definitely they should have the central line in the place, and assess CVP, assess PA pressure, pulmonary capillary wedge pressure and the cardiac index on the daily basis. As I said, for the IVC, if IVC is less than 21, it's a collapsible more than 50%. First thing you give the fluid, because RA pressure seems in this patient is only 0 to 5. And if there is a IVC size is more than 21, still collapsible, then RA pressure looks normal, but again you can load this patient with some IV bolus. But IVC more than 21, non-collapsible, if you give fluid also, there won't be any response. So it's very, very important how you assess your patient. And when you go to bedside, you see a patient, some patient may be very wet, some patient may be very dry. And out of that, some patient periphery may be cold or warm. So everything will give you some clue, and manage your patient accordingly. And because pathophysiology is, both kind of patient will be totally different. So how to treat a patient with cardiogenic shock? First, give 250 ml of saline bolus for 10 minutes. Keep RA pressure around 10 to 14, CWP around 18 to 20 millimeters of mercury. Maximize oxygenation. If patient is having hypoxia, put on the BiPAP, put on the ventilator, discuss with the family, and then definitely you attack a right thing at the right time. That is the key for managing a cardiogenic shock. Give vasopressor, inotropic support. Don't just start dopamine, dobutamine. Just think what pathophysiological patient is having, and accordingly you react. And if patient is having tachycardia, atrial fibrillation, manage accordingly. And correct electrolyte, acid-base imbalance, and phosphodiesterase inhibitor now is easily available, milrinone, amrinone. You can take use of that transiently improve the patient status. Calcium sensitizer, glucosamine has shown the promising result. So you use drug accordingly, and then your result will be optimized. And then once you stabilize the patient, then think for revascularization. If patient is having hypotension continues, just go for angiography. Treat the culprit vessel. If there is a triple vessel disease, just do revascularization. Then patient will do very good. Or patient is CABG patient, explain the family, send for high risk CABG, and patient will do better. Use vasodilator, diuretic at the optimal dose whenever required. One more thing here about the diuretic, we don't change the diuretic dose. Everyday basis we have to titrate the diuretic dose in patient with the cardiogenic shock. That is a very important. Think of ECMO, impeller device. From morning we are discussing about heart transplant. So you think right thing at the right time, definitely your patient will improve. This is the very good article I have taken from Circulation. In every ICU, I think this picture should be there. Not only the medicine dose, but as well as where this medicine act. I think, sorry. The last one, whether it increases systemic vascular resistance, whether it reduces the peripheral vascular resistance, it's very important when you treat a patient with a cardiogenic shock. And again, like if I am treating a patient with cardiogenic shock with AR, those patients need tachycardia. I need to increase the heart rate so that I can reduce the diastole and patient will do better. If tachycardia is not, then I can put even the pacemaker, temporary pacemaker. So what you need to reduce the diastolic phase so that your end diastole pressure will increase and patient come out. So cause-specific therapy is very, very important. Whenever your patient is not doing appropriately, then think of all these complications in patient with MI and you will do better or a patient will do better. I'll just shortly brief one patient with the refractory cardiogenic shock, how I managed this 62-year-old male presented with acute onset of chest pain. He was non-diabetic, hypertensive. He had effort angina for 1 year, but he ignored. His brother had coronary artery disease. And he was rushed to a nearby hospital. His blood pressure was on the lower side. Pulse rate was 54. SpO2 was low. He was put on TPI. Diagnosed as inferior MI and CHB, and he was managed. So now if I manage this patient medically without thrombolysis, mortality is almost 30%. But in the thrombolytic era, the mortality is reduced to 15%. If I do intervention, definitely the improvement mortality is 7%. But if I manage the complication also, definitely I can bring down the mortality to 2 to 3% only. So this patient underwent angioplasty at the different hospital. PDA was occluded and there was residual lesion in the LAD and he underwent angioplasty. Wherever he underwent angiography, result was excellent. There was occluded PDA here. I don't know, where is the marker pointer here? This one? Just show me which is the point. So in the PDA is occluded here. And who had done the angioplasty has opened the PDA, excellent result. And you can see the large PDA which was occluded, and now it is open fully. And excellent result. And what happened now? The patient subsequently discharged from the hospital. He continued on a nocturnal cough and dyspnea. BP was on the lower side, and he had one episode of the PND, and his dyspnea was not subsided, he continued to have dyspnea. And this was the ECG, not very much suggestive, but only tachycardia. And patient was readmitted. He had hypotension, was put on IABP, BiPAP support. There was no improvement on IABP support, and patient still continued to have the dyspnea. Echocardiography was done, which was suggestive of moderate MR. So this patient was explained that patient having a dyspnea because of pulmonary congestion, but the family came to me, they wanted MVR to be done at SIMS hospital because they have advised the mitral valve replacement. On the admission, I saw the patient was having atrial fibrillation. BP was on the 80 millimeter of mercury only. Creatinine was high. Everything was not in favorable condition. He had atrial fibrillation, which I managed with IV quadron. I did portable echocardiography, and there was hardly any MR, grade 2 MR. So I was in suspicion why I should subject this patient for MVR. And I managed the atrial fibrillation with the IV quadron. Now the family was behind me that we brought here for the MVR only, and you are not doing MVR. There is a problem. But I was not convinced that this patient sending for MVR. Then with the team, heart team approach, we discussed everything, radiologist, anesthetist, cardiothoracic surgeon, and we even did the CT angiography also. We found out there is some respiratory problem. And I did TE, and the TE was suggestive of only mild MR. But what surprisingly I could find out, there is a big rent at the apex. So this patient was having subclinical large ventricular septal rupture, which was picked up by the TE. And so whenever your patient do not respond the way you want, this is the way you manage your patient. I will not go detail about the interventricular septal, but subsequent course patient did very good. He was discharged on the 15th day, and this is a follow-up visit. I saw the patient is doing very well. So the take-home message is, managing cardiogenic shock is an art. Proper selection of inotrope, anticipation of different symptom response, and cause target therapy is the key for the management. Medical structural complication has to be managed properly, and early clinical findings, symptoms, investigation finding should all be correlated. And if all this picked up at the correct time, I think it can be life-saving, and your patient can do better, and it will be rewarding. Thank you so much.